So, good evening to all of you, and thank you very much for the introduction. It's challenging to be the last speaker one of the last speakers in the last session. Hopefully, we'll try to make it more interesting to you. I'm sure pediatric topics are very interesting to adult physicians, and try to select the most relevant parts of the topic to adult endocrinologists, as well as audience from the pediatric family in the virtual attendance. So before I talk about congenital hypothyroidism, why we talk about this topic? It's a commonest preventable cause of developmental delay in children. It presents in a very subtle way clinically, so most of children do not have symptoms and signs, and yet this is a high risk of a poor neurodevelopmental outcome. It's a major health problem still in many countries with lacking of newborn screening programs, and when it's detected, physicians need to optimize the management, and knowing the genetics or the genetic background of thyroid development will allow for more therapeutic opportunities. So the outlines of my talk will include a background of thyroid gland and role of thyroid hormone. I will emphasize about genetics, and I will give an overview of the epidemiology of congenital hypothyroidism and newborn screening, and I will give some tips on trends and practical aspects of management. So these tips will include answering some clinical interesting questions like transient versus permanent, the benefits of early exposure to thyroid hormone, when to start treatment, at what dose, and what formulation you should probably avoid, how to monitor these cases and with high TSH, whether this put a risk of differentiated thyroid cancer in the future or not, lifelong treatment, or you can discontinue in some cases. So it's one of the important glands in the body, and it has got a special structure with this colloid in the thyroid follicles with this lining of cuboidal epithelium that when get disrupted can lead to forms of dysgenesis and also to undifferentiated cells predisposing to cancer later on. And the production of thyroid hormone has got a very interesting course of uptake of iodine and then processing this iodide and then later the endocytosis of the T4, which transformed into T3 in the peripheral tissues. And like other glands, the problems can be high or low, can be congenital acquired, and most of the time the etiology is related to genetic causes or immune dysregulation. And the problem can be due to secretory defect or a receptor or post-receptor defect. So we usually resemble this by a shooter and a target, as you know. And the congenital and acquired problems of congenital hypothyroidism can be at 3 levels of the hypothalamus, primary at the gland, or secondary at the pituitary, or tertiary at the hypothalamus. And the problems at primary level would include thyroid dysgenesis, thyroid dyshormonogenesis, which is including number of problems like trapping or peroxidase defect or thyroglobulin defects and iodinization problems, as well as rare entities like resistance to the TSH binding or signaling. And then the secondary or central problem can be isolated, congenital TSH deficiency, or it can be part of congenital hypopituitarism. But also, we classify the thyroid hormone transport or metabolism defect as secondary because this affects the feedback mechanism. An important entity is the transient congenital hypothyroidism, but it constitutes only 10% of the cases, and this can be due to passage of TSH receptor blocking antibodies from the mother and it can be due to other causes. One of the interesting rare entities I have seen during my practice is the congenital hepatic hemangioma associated also with thyroid hemangioma. This is one of our publications giving insights into the situation in the Arab societies. Although the incidence of the condition is similar to the worldwide incidence, however, the distribution of the etiology may be a little bit different with the high consanguinity in the area. So we have more of ectopic type of thyroid, and also the dysharmoniogenesis, all in all, constituting almost 70 to 80% of the cases compared to 20 to 25% of the thyroid dysplasia. As I mentioned, 90% of the cases have got a permanent cause of hypothyroidism, and therefore you have to deal with detected cases seriously and giving a benefit of doubt in treatment. There is increased incidence of transient hypothyroidism in preterm infants compared to term infants. This is interesting report. Our colleague Abdul Hadi Habib from Medina participated in collaboration with a world team of experts, especially in Cambridge, led by Krishna Chatterjee, and they reported this novel homozygous mutation of resistance to thyroid hormone, beta type, and the clinical relevance of that. These patients usually have got some resistance to T4 thyroxine treatment, and they require combined antithyroid drug with triiodothyroacetic acid, which is a T3 treatment to prevent complications like cardiac failure. So they do have this unique phenotype, and there are a number of them here, 5 patients. And this is a gallery of them, including an adult of 39 of age, and they all have short stature, relatively short limbs, hands and feet, and long thorax. So the unique structure and half-life as well of T3 and T4 is also of interest because it helps in monitoring of the condition and monitoring of treatment. And it also has got an importance of differentiating the sick euthyroid entity from congenital hypothyroidism. If we look carefully at the importance of the thyroid hormone at the fetal development, we'll see that there is a transplacental transfer of maternal thyroid hormone in the first trimester. And also the secretion of fetal and thyroid hormone starts from that time and continues at childhood. And this has got a specific importance to normal hearing. In the first 3 years and also during the fetal life, this has got an important impact on the cognitive development, and that's the most critical part of the course of the illness and management. But it also has got an effect on the final adult height because it affects the fusion of epiphyses. In the old ages, we used to see this congenital hypothyroidism, cretin child. But fortunately, this has decreased a lot, but still this is very existing in many countries where newborn screening is not available. So it's something that will need a worldwide approach and campaign to avoid this devastating neurodevelopmental outcome. As I mentioned, in the old ages, they used to use this science of epiphyseal dysgenesis and delayed epiphyseal appearance to diagnose early congenital hypothyroidism because it has an effect on closure of the epiphysis. The thyroid hormones not only affecting the bones and brain, but it has also an impact on the basal metabolic rate, the heart, the gut, and the glucose and lipid metabolism, as well as it's the sensitivity to catecholamines, and that's a very important practical point to endocrinologists when you see a concomitant central hypothyroidism with query hypopituitarism. You need to prioritize the management of cortisol, because if you treat with thyroxine, this will mask the cortisol deficiency, and these patients can be in critical situations when they come to need of stress doses during major stress. So according to the function of the thyroid hormone, symptoms and signs follow. So the patients may present with this jaundice, umbilical hernia, macroglossia, constipation, just name it, all symptoms and signs of a lazy body. Okay, we'll move forward to the tuclids of the genes, or the genetic, the epigenetic factors that determine the correct development of the thyroid. So we have 4 of them: the NKX2, the HX, and the PAX8, and the FOXE1. And this is very interesting slide, maybe the most interesting to you in this talk. So we have this one first involving the thyroid and other tissues as well. So the mice experiments have shown that this will lead, knocking this gene will lead to hypoplasia early in the course of pregnancy, and also will affect the the folliculogenesis. And the PAX8 is very important, also involving these tissues beside the thyroid, and also knocking the embryos, the gene in these embryos can lead to congenital hypothyroidism and death and severe hypoplasia. FOXE1 is the one which is associated with ectopic sublingual thyroid, and also affect the gut, and giving associations with severe cleft palate. And the HEX1 is also involving the heart, the brain, and can risk the survival of the carriers. Still, the other genes relevant for thyroid morphogenesis can be identified. If you look at this list, this can tell about the genes involved in the primary hypothyroidism, those with hypopituitarism, congenital hypopituitarism. Some more will come in the slides about dyshormonogenesis, but also we have this one, MCT8, which is involved with the thyroid hormone transport and metabolism. So medicine translational approach, trying to identify this congenital hypothyroidism related to dyshormonogenesis, or dysgenesis, 3 to 5% of cases may be involved, may have identified genes. Still no model for thyroid agenesis has been identified, and we are looking forward to some more cases and some more mutations and genes to be discovered in this field. So this is more of advanced stage of research in the dyshormonogenesis and signaling defects. The most famous of these problems is the DOX-A2 and the Bendrin, which is famous with the associated syndrome with deafness. This is one of our reports with colleagues in Cambridge and other centers, identifying comprehensive screening for identifying 8 known causative genes in congenital hypothyroidism. And our contribution to that paper with these 2 twins with this rare Papillon-Lefevre syndrome. And this syndrome is associated with some skin and dental problems. So the patient presents with palmoplantar erythema, which change into keratosis, and they lose their teeth early. So as you can see here, one of the twins presented at 8 years already have a denture. And this is associated with cathepsin C gene located in this chromosome, which affects the skin, the dental tissue, and also the thyroid. Right, so the epidemiology, okay. Lowering of the screening TSH cutoff points and changing in the birth demographics and increased prematurity put a burden and helped in identifying the real incidence of congenital hypothyroidism, which actually increased doubled actually from 1,001 in 3,500 to 1 in 1,500. Most of them from ectopic and gland in situ, which is dyshormonogenesis. Unfortunately, it's shocking to hear that 70% of babies worldwide are not born in areas with established newborn screening program. And this is after 5 decades of having these newborn programs well developed in developed countries. So the economic burden of mental retardation owing to congenital hypothyroidism remains a significant public health problem. Do we still have neglected cases of congenital hypothyroidism? Yes, you can see that. These are cases of different age groups from Sudan, and you can see here the one from Yemen, his hand is held by his younger brother who's taller than him and more brighter in intellectual function. So epidemiological studies in this field are minimal, and the incidence of, for example, in Sudan in congenital hypothyroidism is equivalent to the worldwide reported one, and this comes to this conclusion of around 250, 350 cases per year. And implementation of congenital hypothyroidism screening program would potentially avoid the neurodevelopmental consequences in these patients. We called for this program in 2012, and this was hopefully in progress before the war started. So, heel brick versus cord blood. So the heel brick is a commonly used method of newborn screening as Guthrie test in the European countries in day 2 or 5. In preterms, it's used early. In Saudi Arabia, there is more of discharge early after birth, so cord blood and also home birth. So cord blood is also in use, and each area should choose the most suitable technique that will improve and increase the detection rate. So this is a report from a couple of my colleagues in my center who looked at the cut points for the TSH for cord blood versus heel brick. And obviously the cut points are very different from the commonly used in practice. So you need to be familiar with that. Usually they use 60 international unit, okay, milli international unit as suggestive, highly suggestive of the diagnosis. 30 to 60 is questionable or a query, and less than 20 or 30 is clearing this patient. There are different strategies for newborn screening, so using TSH and backup T4 method. This is commonly used in many countries, Europe and Japan, and there is a worldwide move for this one with improved techniques of detecting TSH. The Americans still use the T4, primary T4 with a backup TSH method, and the only advantage of this one is that not to miss central types of hypothyroidism, which is only 1 to 2% of total. So the normal pathway is notification of any possible cases, call for history, and check the maternal medications and also baby medications, examine for goiter and signs of hypothyroidism and sublingual thyroid, and start treatment as early as possible. Knowledge of normal fashion of the features of the lab features. Can I have my slide back, please? Okay, normal features of the thyroid and TSH is important because also it will help you to avoid unnecessary investigations and treatment. And according to the screening method used, normal or abnormal, you need to follow such algorithms. Last but not least, I will talk about any possible association of congenital hypothyroidism with thyroid cancer. This is a recent report, very useful, from Brazil, and it postulated a hypothetical model of process of carcinogenesis in dyshormonogenic thyrocytes. And they focus on oxidative stress and others that may lead to differentiated thyroid cancer cells. So the postulated theories is long exposure to TSH, stimulating factors or lack of tumor suppressor genes, type of mutation, and the presence of congenital goiter. But as you heard earlier from one of the speakers, that this can be masked and biased because of more ultrasound being done in this pathology entity or these patients, and this will lead to higher detection, obviously, of DCT. So the diagnosis is based on a screening test and confirmatory test, and also some images that can be very helpful in identifying small thyroid or dysgenesis, as in this technician scan. The management, optimal cognitive outcome is an outcome of obviously the optimal and adequate treatment, normalizing T4 within 2 weeks, TSH within a month, and starting 10 to 15 mic per kilo. Generous doses can lead to craniosynostosis. However, you need to prioritize the risk of neurodevelopmental outcome. Usually, hypothyroxemia of prematurity does not need a treatment, and we usually prefer crushed tablets because the solution, there is a big question of the sustainability of thyroxine solution. So we space out the follow-up period depending on the age, because the critical age is the first 3 to 4 weeks of life, and the IQ diminished significantly if you delay the management. Patients with dysharmoniogenesis, usually you may discontinue treatment after 3 years, and if the TSH rebounds high, that means the patient will need treatment for life, because this is a permanent. Can I have this? I have only one last slide, actually. Okay. Okay, so the outcome, early treatment will lead to better outcome. I mentioned this already, I will skip this part. There is some evidence of low thyroid hormone on the fetal brain, and the maternal low thyroid hormone can affect the fetal brain in functional studies. So the research perspectives is early treatment can also still have some devastating effects on the auditory brain function. So this may question whether we need to start the treatment early during pregnancy. And I already showed you the effect of maternal hypothyroidism on fetal brain. And in addition to that, more genetic studies and discoveries may lead to better outcome. So in summary, congenital hypothyroidism is the commonest treatable cause of developmental delay. Newborn screening is the most cost-effective program in avoiding such devastating problems, and almost all affected newborns have no symptoms and signs, so need a high detection or suspicion. And okay, I probably stop there and leave the chance for the next speakers. There are some more conclusions, but you heard about them in my slides. Thank you very much for listening.